Hello everyone. Welcome to this presentation on the SOFA-2 score, the updated sequential organ failure assessment tool for evaluating organ dysfunction in critically ill adults. I am Docsaab and I'll be guiding you through this evaluation criteria and applications. The SOFA-2, published in JAMA on October 29, 2025, addresses the limitation of the original 1996 SOFA score by incorporating modern therapies like non-invasive ventilation, high-flow oxygen, and advanced organ support. This is essential for anyone managing sepsis, ARDS, or multi-organ failure. By the end, you will be able to calculate and apply it confidently. Let's begin with the basics. Let's start with the introduction. The SOFA-2 evolved from the original SOFA, which was groundbreaking in 1996 for identifying organ dysfunction in sepsis patients. It is used a 0 to 4 scale across 6 systems to quantify failure severity, but it hadn't been updated in 30 years despite advances like ECMO and NIV. The SOFA-2, developed through a global consensus of 28 countries, shift the score distribution, example like more patients score higher in respiratory and cardiovascular domains due to better support. Its purpose is to describe organ dysfunction in critically ill adults, aligning with the Sepsis 3 guidelines where a SOFA change of more than 2 from baseline indicates organ failure. Significance: it is a common language for ICU teams, predicting mortality risk and guiding intervention. For instance, in a patient with sepsis-induced ARDS, SOFA-2 helps quantify how many organs are failing. Think of it as a multi-system dashboard for prognosis. These updates ensure we are not underestimating dysfunction in today's era of advanced care. Next, the methodology behind SOFA-2. It was developed using a rigorous evidence-based approach, Delphi consensus with 100 plus experts, followed by validation in massive datasets, over 3 million ICU admissions from 2010 to 2023. The process considered contemporaneous changes like higher survival with NIV, shifting thresholds for better accuracy. Key differences from SOFA-1: updated respiratory criteria for PaO2 divided by FiO2 ratio and NIV HFNC ratio, cardiovascular thresholds for MAP and vasopressors, exclusion of immune and GI scoring due to weak evidence. It assumes resource availability, but adaptation exists for low resource settings. For example, in a validation study, SOFA-2 predicted ICU mortality more reliably in diverse population, including those with cirrhosis or trauma. This consensus ensures the score is both robust and practical for real-world use. Let's get into the organ systems, starting with the respiratory. This domain assesses oxygenation and ventilation, critical in conditions like pneumonia or sepsis-induced ARDS. The criteria focus on PaO2 FiO2 ratio and non-invasive support. Let's discuss detailed criteria. 0 means non-dysfunction, that include PaO2 FiO2 ratio more than 400 and no NIV HFNC support. 1 means mild, that include 300 to 399 ratio and no support. 2 means moderate, that include 200 to 299 ratio and no support. 3 means severe, that include 100 to 199 ratio and no support. And 4 means critical, that means less than 100 ratio or requiring NIV or HFNC support. Interpretation: a score of 4 indicates severe hypoxia, often needing intubation. Mortality risk jumps to 70 to 90%. For example, in a COVID-19 patient with PaO2 FiO2 ratio 80 and HFNC, this score 4, signaling rapid escalation. Track trends: a rise from 2 to 4 in 24 hours predicts 50+% mortality. Cardiovascular criteria evaluate hemodynamic stability, key in shock states like septic or cardiogenic shock. It uses MAP and vasopressor dependence. Detailed criteria: 0 means stable, that include MAP more than 70 mm mercury and no vasopressors. 1 means mild instability, that includes 65 to 69 MAP. 2 means moderate, that includes 60 to 64 MAP. And 3 means severe, that include less than 60 MAP or vasopressin less than 0.03 units per minute. 4 means critical, that includes vasopressin more than 0.03 or norepinephrine less than 0.1 or epinephrine less than 0.01 or dopamine less than 5 or dobutamine more than 5. Interpretation: a 4 score obtained means vasoplegic shock, mortality over 80%, as in patient with MAP 55 and norepinephrine infusion. Non-invasive support like NIV can mitigate, but a score of 3 flags high risk. Clinical example in post-cardiac surgery patient with MAP58 and low-dose vasopressin, disease 3, prompt fluid challenge or inotropes. Hepatic and coagulation system assesses liver and clotting function common in sepsis or liver failure. Hepatic criteria 0 means normal, that include less than 1.2 mg per deciliter bilirubin. 1 means mild, that include 1.2 to 1.9 bilirubin. 2 means moderate, that include 2 to 5.9 bilirubin. 3 means severe, that includes 6 to 11.9 bilirubin. 4 means critical, that include more than 12 bilirubin. Interpretation elevated bilirubin indicates cholestasis, scores more than 3 linked to multi-organ failure as in cirrhotic patient with bilirubin 15, mortality more than 90%. Coagulation 0 means normal, that includes more than 1,50,000 per microliter platelets. 1 means mild, that include 1 lakh to 1,49,000 platelets. 2 means moderate, that include 50,000 to 99,000 platelets. 3 means severe, that include 20,000 to 49,000 platelets. And 4 means critical, that include less than 20,000 platelets. Interpretation thrombocytopenia signals DIC, scores more than 3 predict bleeding risk, like in trauma patient with platelets 15,000, score 4. Combine this highlight metabolic derangements. Renal and neurological. Renal uses creatinine for kidney function and neurological uses GCS for brain status. Renal criteria 0 means normal, included less than 1.2 mg per deciliter creatinine. 1 means mild, that include 1.2 to 1.9 creatinine. 2 means moderate, that include 2 to 3.4 creatinine. And 3 means severe, that include 3.5 to 4.9 creatinine. And 4 means critical, that include more than 5 creatinine. Interpretation rising creatinine shows AKI, scores more than 3 means dialysis likely with mortality more than 70% as in septic patient with creatinine 6. Neurological 0 means alert, that include 15 GCS score. 1 means mild impairment, that include 13 to 14 GCS score. 2 means moderate, that include 10 to 12 GCS score. 3 means severe, that includes 6 to 9 GCS score. And 4 means critical, that include 3 to 5 GCS score. Interpretation though GCS indicates encephalopathy or coma, scores more than 3 signal poor outcomes, especially with organ support like sedation. Impact ECMO or NIV can lower scores by supporting other systems. Clinical example a head injured patient with GCS4 needs neuroprotective measures. Moving to clinical applications, SOFA-2 is sequential, calculate on admission and every 48 hours to track progression. It monitors dysfunction in real time, guiding sepsis management, a score of more than 2 flags sepsis, prompting bundles like antibiotics and fluids. For resource allocation, high scores prioritize ECMO or transfers. In treatment strategies, it informs escalation such as vasopressors for cardiovascular failure. Clinical example, in sepsis patient, baseline SOFA-5 rises to 10 in 24 hours, triggers severe sepsis and ICU transfer. Sequential assessment reveals trends. A rising score predicts 50% plus mortality, while stability suggests recovery. In diverse ICUs, it standardizes care, reducing variability, such as in low resource settings, it helps triage limited beds. Prognostically, SOFA-2 excels in mortality prediction. Mean scores more than 5 or highest more than 11 correlate with more than 80% mortality, such as in cirrhosis, more than 10 predicts 93%. A 2-point change in 48 hours is significant regardless of baseline. Compared to SOFA-1, it is more accurate and outperforms Apache in sepsis context. Implications, early high score guide palliative discussions, trends inform outcomes such as a drop from 12 to 6 post-intervention signals improvement. In a validation study, SOFA-2 show consistent mortality relationship across 3 million patients. In summary, the SOFA-2 is modern, validated update to assess organ dysfunction across 6 systems with a scores 0 to 24 indicating severity. Key takeaways, it incorporates contemporary support, predicts mortality better than SOFA-1 and guides ICU decisions. Ongoing research refines it for AI integration and global validation. Impact, it standardizes critical care, improving outcomes in sepsis and beyond. Thank you guys. If you have any questions, then contact me via comments or DM me on Instagram. And please like, share, and subscribe to the Docsaab's Diary.